Good evening, doctor, colleagues and friends. I am Kalyan Goswami, Regional Head, Abbott Vascular, based out of Bangalore and responsible for the Karnataka and the East business. On the eve of the Festival of Lights, I extend all of you and your family a very happy and prosperous Diwali in advance and sincerely wish everyone a very good health and happiness during this pandemic. Today's evening webinar is titled Guiding Through Complexity E CONCLAVE 1 and it has some interesting topics being presented by four eminent speakers. And to moderate today's proceedings, we have Dr. Binayak Deb. He is a senior consultant and intervention cardiologist from Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. So I would request Dr. Deb to commence today's proceedings. Thank you, sir.
Thank you, Kalyan. Thank you, the whole of Abbott team and the esteemed speakers and panelists for being with this program today that is guiding through Complexity E CONCLAVE 1, which means that it's a program which we are actually initiating probably. And it's very nice to see Dr. Chadha amongst us. So, and also, as Dr. Chadha mentioned, he's in his hometown. I am also with my two hometown boys, Dr. Behera and Dr. Biswaranjan. They are also, I also come from Bhubaneswar and Cuttack, so these are my hometown boys as well. So it's a kind of a reunion of our hometown during the Diwali. That's great. So today we'll be discussing a few topics, particularly on complex interventions and also some topics which are very pertinent to this COVID era. So how interventions are being influenced during this era, we'll be discussing that in a couple of topics as well. And obviously, Dr. Chadha will be talking one of the most important topics, the precision PCI, guided by the image. Because I believe that, I've been doing imaging since 1991-92 when angioscopy was starting in this world and IVUS was also in its nascent stage. And I also believe that seeing is believing, because angiography, as we know, is all about, imaging and ghosts. And the OCTs and the IVUS obviously is actually the real thing. So Dr. Chadha will be talking about that. So I'll have a short presentation before we start, and let me share the screen then. So I'll be just talking about a short topic on drug-eluting stents and where are we. Because we all know that when we started from the POBA days, at least I was one of the operators on those days in 1985-86, and the first stent was implanted by Dr. Ritesh Kumar in 1987, and from then on, the bare metal stent, and then the drug-eluting stents came, and then the bioabsorbable stents came. So these are the kind of the evolution of the stents. So where exactly are we in the terms of drug-eluting stent? When we started with the drug-eluting stent in kind of 2002, when it was available to us commercially, we talked about a metal platform, about a durable polymer, and a limus drug. These are the three main components of a drug-eluting stent. But now, not necessarily that the platform has to be metallic. The polymer can be temporary or even absent. And the limus drug, as you know, we have different formulations nowadays. So why do we need to improve? Because as you know that the clinical outcome has correlations with the device success. Because at the end of the day, we talked a lot about the clinical outcome. We have lots of clinical trials, observational studies, and we have the primary endpoints as the MACE and the mortalities, which are the clinical outcomes at the end of the day. But we have to understand that without device success, without the device being delivered at the point of the problem, we cannot actually have a good clinical outcome. So it has a direct correlation. So the platform, the polymer, and the drugs are the issues which needs to be talked about. When we talk about platform in the drug-eluting stents, we are talking about trackability of the stent, we are talking about the crossability, pushability, stent designs, strut thickness, and the radial strength of this stent. So the problems with the DES polymers were obviously the chronic inflammation. We have lots of studies from Renu Virmani, who actually talked about this hypersensitivity, chronic inflammation, delayed neoatherosclerosis and thrombosis. She has given a lot of insight into these problems. The solutions came with biocompatible things, and then we have engineered to disappear after a period of time, like the bioabsorbable stents. And then we had the drugs, either it was conformal or it was abluminal. So those are the issues, kind of this, and the solutions briefly. So progress with DES, are we done? So we have a good article from Dr. Capadanio in 2019, and he was talking about areas where we need to have progress, where we have problems and where we need to have progress. So one area of concern with DES was the stent thrombosis and the restenosis. The target lesion failure and the TLR was doubled in diabetic, because diabetic populations are actually problems in the interventions, because if we see that that is only one area where if you have a diabetic triple vessel disease, the CABG surgeons, they tell that they have a better outcome. So that is one area where the drug-eluting stents needs to be comparable with that CABG, and the fractures in the neoatherosclerosis with the stents. And the other issue with is the high bleeding risk with the long dual antiplatelet therapy. The ideal drug-eluting stents is, we're talking about a low profile, thin studs, high flexibility, high radial strength, and it has to be mounted on a high pressure balloon, because we know a lot of lesions are difficult to crack. They have calciums, they have tough fibrous tissues, so a high pressure balloon always helps. And obviously good visibility under fluoroscopy gives you precision when you are actually doing the stents. So the ideal deaths, again, we have the drugs which should elute in 2 to 3 months, early endothelialization and thromboresistance, and minimal neoatherosclerosis and target lesion failure should be very low, and trivial late loss and require only 4 weeks of DAPT. That's one of the areas which needs to be also discussed about. So the question begs, are we asking for too little, too much? Because as you see from the slides, that that's how the whole angioplasty thing started in a kitchen, where actually Dr. Brunzik started designing his balloons and catheters. And from 1977, then it came to 1986-87 when Dr. Sigwart and Dr. Pohl, they did the bare metal stent. Then we had the Revolution 3 of 1999, drug-eluting stents, and then the 2011, the bioabsorbable stents as well. So the question is it too much we are asking for? Now, if we talk about the Xience everolimus drug-eluting stent system, from 2006 Xience V to 2009 Prime, and then Expeditions, Alpine, and very recently the Xience Sierra, which is not available yet in India, but it's one of the better stents with a lot of designs and results which are pretty good. So the design pillars of Xience are based on the Multinic design stent design, which gives a good deliverability. It has got a good efficacy and safety data, which is very, very important. The efficacy and safety of any medications, of any vaccines or any device is so very important. It has to be efficacious and it has to be safe. So those are the things which have been has to be important for the devices as well. So for peak performance with Xience, from simple lesions to complex lesions like the CTOs, they have been doing very well. Low risk individuals to high risk patients like those, as I mentioned, the diabetic subgroups. So the Xience Sierra is probably the ultimate best so far. It's come in 2017. It's got an ultra low crossing profile. It's got a slim flex technology, and it's got a maximal expansion, because particularly when you are doing bifurcation lesions, including the left main. So the expansion, when you're doing a pot, the Xience stent, the Xience Sierra stent actually can expand to up to 4.5 to 5.5, and that helps a lot without actually losing the radial strength and the texture of the stent. So the Xience Sierra probably is one of the ultimate deaths. I'm sure that other stents will also be coming in that category. It's got a good deliverability, crossing profile, to post dilate to 5.5, minimal stent shortening, and a catheter optimized for strength, flexibility, and pushability, and excellent apposition and complete expansion, because you have got a good balloon to deliver that. Now, the thromboresistance part of the stent is very, very important, because we understand that a comparison of acute thrombogenicity and albumin absorption in 3 different durable polymer coronary drug-eluting stents is one of the studies which have been done because we understand that the thromboresistance is an ideal property for coronary stents. It will prevent from the thrombosis, and it will have a minimal inflammatory response and functional healing. So superior thromboresistant features of polymers may contribute to the short DAPT regimen. So the STOP DAPT trial with designs which has been done, it's a randomized controlled trial, and the interpretation is that among patients undergoing PCI for stable and unstable cardiovascular disease, 1 month of DAPT followed by clopidogrel monotherapy was superior to 12-month DAPT followed by aspirin monotherapy at preventing net adverse cardiac clinical events. So the evidence-based choice, obviously, Xience comes very close to it, particularly with the Xience Sierra. That stent has kind of fulfilling all the criteria which we want from a drug-eluting stent. The Xience story is about 15 million implants so far worldwide, 120 plus clinical trials, 125,000 patients studied, and more than a decade of experience with these stents. So the experts like Greg Stone has said that from all the data today, every study that's been published, we have seen the lowest rates of both early and late stent thrombosis with fluoromer-coated aluminum stent, and the best safety profile to date is with the fluoropolymer-based devices. So in India, we have 15 lakh happy hearts, and till the last quarter, like March, we would have had about 15 lakhs Xience stent implanted. So that's a huge milestone for the Abbott. And my PCI journey started from the POVA dates from 1987 till date, and I've been blessed with be working with many operators across the world. So it's a wonderful feeling actually to be talking and sharing our experiences. Like Dr. Chadha will be sharing his experiences with the young operators, experienced operators at such a young age. So it's a wonderful feeling to be with you all. So with that, I conclude my presentation.
Thank you, Dr. Deb. That was a very crisp, to the point presentation highlighting all the virtues of an ideal drug-eluting stent. And as you very correctly brought out, we are still, in that journey where we need to get one, because you improve on one aspect, you have to compromise on the other. Like you improve the, strut thickness was a major issue. You reduce the strut thickness, the radial strength was partly compromised. And polymers have been a long story, from durable to biocompatible to biodegradable. We've gone through that journey, and you kind of summarized everything in a very short and in a very lucid manner. So I see no questions in the chat box. So yes, Xience has been the gold standard against which most of the other platforms have been compared. And but since I am on the stents, and I would add that a couple of stent platforms which do very well in the bifurcation are the Ultimaster and the Medtronic stent, which is made out of a single coil, because you need, when you're doing bifurcation and you need side branch access, these are two stent platforms which give you a very good side branch access, because their cell sizes are relatively bigger, and the expansion for a given diameter is also pretty good. So if any of the panelists would like to add anything, otherwise I'll request Dr. Deb to introduce the next speaker and we can go on to the next talk.
So thank you so much, Dr. Chadha, for your input. So we'll move on to our next talk, which is actually by you. Let me introduce Dr. Chadha. It's my pleasure and privilege to introduce Dr. D.S. Chadha. He's a senior consultant cardiologist at Aster RB Hospital, Bangalore. And we know Dr. Chadha very well for all the work he has been doing across so many years. He's been associated with the Armed Forces Medical College Medical Services since 1992. And he is working in the field of medicine for the last 31 years and experienced in cardiology for the last 17 years, interventional cardiology. He has been invited to various international and national forums as a trainer, and also presented numerous papers at national and international forums. and is credited with several publications with various national and international journals. Of course, his areas of expertise are complex coronary intervention, rotational atherectomy, imaging, physiology, leadless pacemaker implantations, TAVI, endovascular repairs of aortic aneurysms, and device closures. So, and he's going to talk about a very, very important topic of image-guided precision PCI. The word precision is actually the key word in this whole story. So, over to you, Dr. Chadha.
Thank you, Dr. Prabal. That was very generous of you. I'll set the ball rolling. Yes, image-guided precision PCI. The first question which you invariably get asked is there a need for imaging? And this comes universally from wherever I've been, and I've been asked this: that do we need to really image? Yes, you do need to image. I show you a case of trifurcation, which was done successfully, and before we ended the procedure, we thought we'd do the first do a final closing OCT, and this is the OCT run on completing the trifurcation. We put 3 stents because the vessels are big. I'll be coming back to this case, and this is what we discover. Now, what we discover is that if you can appreciate in the lower longitudinal cut, that there is a geographical miss. So what has happened is that we have missed out, even though we thought we've stented completely, but there is a lack of overlap between the left main and the LAD stent, and more importantly, the distal LAD stent was malopposed. So this is what you normally pick on imaging. In yet another case, a simple, straightforward circumflex angioplasty, which was completed, and we thought we'd done a good job. And when we took the OCT run of this, we realized, as you can appreciate on the screen, there is considerable underexpansion. This is the view which reveals that marked on the red are the underexpanded stent struts, and you can see them floating here. The struts are floating. So angiography has not helped us pick any of this in these 2 cases. So we optimized, and post-optimization, we took whatever was red has turned white now. So that means in this fly-through view, what we appreciate now is the stent is probably very well approximated. Everything which was red in the fly-through view taken earlier has become white. Stent is well opposed, as you can see in this cut view. So invariably, the operators come up and say that I can see it all, and my weapon is stent boost. So this is a universal answer which I get to hear in multiple platforms. So when you use stent boost, you feel very confident that you've seen it all. But does it really show all of things which we want to see? I'll show you certain case examples. It does not pick up geographical miss. That was in the first case. It does not pick up malopposition, which I showed in both the cases. In addition, it is very difficult to appreciate underexpansion. What happens, what I mean by underexpansion is that the true vessel diameter assessment becomes difficult, but stent boost will show you uniformly expanded stent. It will not, if there is some amount of underexpansion, you will pick up. But whether this well expanded stent is opposing well or not, you're not very sure. It also will not pick up any plaque protrusion and will also miss out on edge dissections. So the answer for this question is, can I see it all? It's a simple no. And why so? Because angiography has a lot of limitations, and to name a few, it becomes very difficult to pick up eccentric lesion. There is poor sizing of the vessels. You are bound to have some geographical misses because, and I will show you case examples as my talk goes on, because you can assess, it's a pure luminogram, but it's very difficult to assess the plaque composition, the extent and distribution of plaque. And there is, no 2 operators will agree to the findings where sizing or the length of the lesion is concerned. And a gamut of post-PCI complications which are often missed. So there is a problem, and there are certain mistakes which we certainly commit while evaluating these patients. So it's our desire to see and and seeing is believing, because what you see is not always what you get. So the journey of intracoronary imaging started with IVUS. Dr. Deb was mentioning he's a very senior operator and he's seen it all and done it all. So IVUS was the first tool which was made available, and it certainly transformed the results of intervention, and especially in the high-risk subset. And banking on the lessons which we learned from the IVUS, now we have a new tool which is OCT. IVUS uses sound waves, whereas OCT uses infrared light, and it gives you very clear magnified images at a phenomenal speed. Now, where is the evidence in support of imaging? There is lots and lots of evidence available for IVUS, and as you can see on this slide shows you the stent failure rate, which is to the tune of 15 to 20%, and when you use IVUS, this rate really drops, and there is considerable reduction in the rates of target vessel failure. And there is this is what was seen in the ultimate study. And when you see the opinion trial, which compared the IVUS and OCT, the results were shown to be absolutely similar. The target vessel failure rates were similar with both IVUS and OCT, and that led to a fact that certainly if you add either IVUS or OCT, your results are going to be much better. How does it affect? It basically helps you change your decisions in terms of increasing the stent expansion in the way of appreciating major malpositions, and also it picks up certain dissections. And this is what we saw in iLumen 3, and the percentages are given here. There was considerable change in the degree of the abnormalities which were picked up, and it certainly led to change in the clinical outcome. So what we are essentially targeting in any given clinical situation is that, yes, I've changed my decision, but has it really helped in improving the clinical outcomes? Well, we had the CLI PCI data, which clearly showed that there was considerable reduction in the cardiac death, and the rates of myocardial infarction in those patients who had undergone revision of their strategy based on OCT findings. Well, OCT and IVUS both are Class 2A. They enjoy the Class 2A recommendation. This is as per the 2018 ESC guidelines. And the important issue here is how to use OCT for Pci optimization. Now, this is the new mantra which we are using, which is called the MLD Max. MLD stands for morphology, length, and diameter, and Max stands for medial dissection, apposition, and expansion. So essentially, what you're looking for is checking on the morphology, length, and the diameter of the lesion. So let's look at the MLD first, assessment of the plaque morphology, which is very, very important. This was a very late stent thrombosis, which presented a bare metal stent, which came to us with ACS, inferior wall MI, and when we run the OCT, we picked up considerable neointimal hyperplasia, and we also picked up a ruptured plaque, as you can see here, and there was a lot of red thrombus which was noticed. So the etiology was pretty clear. Another young patient, a smoker who came with anterior wall STEMI, and the vessel was studded with thrombus, as you can see in the OCT run here. You can see a cloud buildup. This is nothing but the red thrombus which is there in this vessel. And what you can appreciate is at the 10 or 12 o'clock position, or now if you see the main vessel wall, there is hardly any atheroma in the vessel wall. So there was just a red thrombus and no atheroma in the vessel wall. So there was plaque erosion and there was clotting. And when we repeated the OCT, there was nothing in the vessel wall. We didn't stent. We normally, when we get such patients, we don't stent. We just put them on dual antiplatelets along with anticoagulant for about a 4-week period and repeat an angiogram. And the same was done in this case. And we could appreciate the diagnosis, a case of plaque erosion. A young lady who presented with, again, ACS, she had an ectatic lesion in the distal RCA. When we run the OCT for her, we noticed a dissected flap which was filled with thrombus. Now again here what we noticed was there wasn't any significant atheroma in the vessel wall. So this was a case of RCA dissection. As you can see, there is hardly any atheroma there. and the dissected flap led to formation of thrombus. So we didn't do anything for her. We just put her on dual antiplatelet. So what I'm trying to imply is that if you've used OCT, you can withhold the stenting. You can give the right kind of therapy which these patients need. Again, anterior wall STEMI, which was taken up for primary angioplasty, which was done successfully at the time of completion of angioplasty. As you can see in the lowermost frame, we noticed some amount of left main disease. There was some damping of the pressure of the guide catheter also. We run an OCT at a later date. Normally, when we do the primary angioplasty, we don't do OCT in the same sitting because we like to conserve the contrast in these patients. We run the OCT primarily looking at the proximal LAD and the left main segment. What we noticed is there are a lot of healed plaques, and I'll give you by definition what is a healed plaque. And in addition, we also noticed a lot of unstable plaques in the left main segment, which was certainly, stenosed compared to the remaining vessel. So this is what is an unstable plaque with thin cap fibroathema. It's akin to a pustule which is about to rupture. We also notice, as I told you, healed plaques, which are also termed as layered plaques. These are plaques which were seen in the proximal LAD and the entire segment. We also noticed there was under expansion of the stent, and yes, there was left main stenosis. So what are these layered plaques? Layered plaques or the healed coronary plaques are the ones with one or more layer of different optical density, which basically signify that there is panvascular disease, there are culprit and non-culprit lesion, and there are different stages of evolution. That means whenever we notice some unstable plaques, they might rupture, and not all the plaque ruptures lead to coronary events because they rupture and the indigenous lytic system takes care of what follows after the rupture, and you don't get classical acute coronary syndrome. So what clinical studies have revealed is that they are commonly seen, the layered plaques are commonly seen in stable angina pectoris patients and more commonly in patients with multivessel disease, and invariably these patients have significant diameter stenosis. What do they mandate? They mandate that we put these patients on long-term lipid-lowering therapy, and DAPT duration has to be longer if you pick up these plaques. So we took up this patient and we kind of stented the left main segment, as you can see here, and we also optimized the proximal LAD. So distal, proximal, and the LMCA segment now were well optimized at the time of discharge. Now, there are occasions when a patient with ACS comes and you feel that you really don't understand what it is, whether it's a chronic dissection or a recanalized thrombus. So OCT comes handy. It basically tells you, in this index case, we took the OCT run, and this shows you a classical recanalized thrombus, which kind of shows you a honeycomb appearance, and you have multiple septae which are there, and this basically rules out a significant coronary dissection. And these are the patients where the thrombus has gone. So these give you a lotus stem or a honeycomb appearance, a classical picture. And in addition, in the proximal segment, we also notice certain microchannels, basically signifying that this patient had a lot of unstable flux in his vessel, which led to rupture and thrombosis, and the indigenous lytic system led to recanalization of this thrombus. So we kind of stented this vessel with good results. Calcium is the nemesis for of the good results. One is that you either fail to deliver the stents, or even if you deliver, you are not in a position to optimize. So calcium can be deep or superficial. These are examples of thick, deep calcium, which is not much bothersome. You can easily go ahead and do angioplasty in these vessels without significantly compromising your results. Or it could be thin. Thin calcium is best picked up with IVUS because in OCT, the depth of penetration is not very good, so it is often mistaken as lipid-laden plaques. Superficial calcium can be thin plate, or it can be nodular, as shown in the lower, or it can be circumferential. That means it's nearly 360 degrees of calcium which is there. So calcium, the mere recognition of calcium mandates that you have to sharpen your tools and you come back. And I show you a case which we had done just pre-COVID, 75-year-old male. He had class 3 angina. He had native TVD. So as you can see here, RCA was filling from the LAD, and this fellow refused CABG. There was kind of near total occlusion of RCA with faint antegrade flow. That means there was some microchannel which was present. We did rotablation of the LAD lesion, and LAD was stented subsequently. And this individual was told that you come back within week 10 days so that we can address your RCA. And thereafter lockdown happened. He was lost to follow-up. In the month of April, he had some chest pain. He was asymptomatic thereafter for 3 months. And when he presented to us in the month of August, he had some QS complexes in the anterior leads. And the normal LV now was moderate because he had developed some LV systolic dysfunction. We took him up for CART, and what we noticed was that there was some filling defect in the LAD in the distal part of the stent. So that means he had stent thrombosis. RCA continued to fill, and RCA was now the whatever little antegrade flow which was there in the RCA had stopped completely. So we took him up, we took a filter XT wire, we cross-dilated, and post-dilatation the flow in the RCA was established. Now we took an OCT run, and on OCT it showed us complete spectrum of what a calcific coronary artery looks like. We had anything and everything which one could see in one particular vessel. The entire spectrum of a calcific plaque was seen. As you can see here, there was nodular calcium jutting in. There was a fibrocalcific lesion. That means there was calcium and very thick fibrous plaque which was present, and the extent was pretty large. We also noticed thick calcific plaques which were there all around. And we had kind of circumferential calcium covering the entire length and breadth of the vessel. So we took up this patient for rota. We rotablated the RCA lesion, and now we use the new tool, which is the intravascular lithotripsy. We chose, I think, a 2.5 millimeter balloon, and we delivered pulses from distal to proximal to the entire extent. And I'll show you some amazing images of post-IVL OCT. So we could pick up the fracture. You can see the fractured segment of a thick plaque. We can also see the fractured calcium plate. The circumferential calcium plate had completely fractured. And you can also see, because this balloon is normally inflated at 4 atmospheres, when you deliver about pulses for 10 seconds, you can see the fracture fragments very well on your screen. Now, the basic advantage of IVL is that it basically fragments the calcium within the vessel wall without causing significant dissections. You can do it with an additional wire in the side branch in place. There is no risk of any no reflow or slow flow, and the chances of perforation of vessel are bare minimum. But the downside of IVL balloon is that it's a bulky balloon. It is 044, so you need to have some kind of passage available for this balloon to get in. So we stented the distal RCA. We optimized the distal RCA stent, and we were pretty happy. We took another OCT run. Now the vessel had opened up. When we came to the proximal part, there were no dissections, but what we noticed was that there was certain unstable plaque. So the distal stent edge was pretty good. The proximal segment was also pretty good, but we noticed there was dissection proximally. Now, mind you, on the angiogram, nothing was seen. So we picked up, by doing an OCT post-procedure, we picked up not only edge dissection, but we also picked up the residual calcium, and there were certain unstable plaques in the proximal part of the RCA. So, having noticed this, we couldn't leave this here, but I'm reasonably sure, had one not been using OCT, all this would have been left to the fate of the patient, and I'm reasonably sure the patient would have come back within a short while. So we stented the proximal RCA with good results, and this is the lumen file which you get in the OCT, and you can see progressively the upper frame shows you without the stent, immediate after stent implantation, and this is after optimizing. So these are the images which you can generate from OCT, and it tells you that your stent is now uniformly and very well expanded, and this was the final run of the RC, and it really looked very nice. We then went on to address the LAD lesion which had the thrombus, and since we had about couple of pulses left with the IVL balloon, we also did the IVL of the LAD, and we opened up this strut, which was responsible for an ACS in this patient. Well, bifurcation segment, it's really, really important to use OCT, and it helps you image the, most importantly, I'm laying stress here, that it helps you image the main and the side branch. It tells you the complexity which you're going to deal with by assessing the morphology in these two segments. And most importantly, it helps you select the 1 or 2 stent strategy. And it also aids in the wire crossing. As we know, whether we are doing a provision or the 2 stent strategy, we need to go through a particular cell of the stent to get good results. And it finally optimizes the results, that is by telling you whether there has been any post-stenting complication. So in all respect, it helps. In view of paucity of time, I'm not showing you bifurcation cases, but it's a very important tool. Well, this was the trifurcation case, and now I've stressed upon the sizing. And I think when we started this case, the best sizes we noticed was we thought we'll do LAD 3.5 and LCX looks good for about 3, and we had kept Ramus as provisional. We thought we'll not do anything with the Ramus because we were pretty sure. So we took after having studied this, we took the OCT pullbacks from LAD to the left main, and we certainly were wrong. The LAD was around 4.5 millimeter. So the proximal LAD was coming 4.5 and the left main was about 5. So we were going wrong by nearly 1 millimeter here. And then we took a run pullback from the circumflex to the left main. And here again, we had gone wrong. The circumflex, it revealed that it had a lot of calcium, which angiographically we had not appreciated, but most importantly, the size was also 0.5 millimeter more than what we had guessed on the angiogram. And there was significant disease at the ostium of the circumflex, so which wasn't so apparent because the lesion was eccentric. So OCT helped us, pre-stenting, change our complete strategy for this patient. So this slide basically tells you how you size. You have, as we know, whenever we are doing a bifurcation stenting, you need to have the distal proximal references, and you have to accurately assess the lens. And what we use normally for assessing the size is, when you can see all the 3 layers, you use the EL, external elastic lamina. If you can't see that, then you look at the lumen, and you always go from a segment which shows you less than 50% of plaque, or where you can see at least 180 degrees of the 3 layers of the vessel. And that is how you select the stent length. And in this case, given case example, the stent length which was selected was around 14 millimeters. Now, is the measurements which you obtained from OCT accurate? Well, we have a very nice paper in the JACC imaging which came in 2013, and it clearly shows that if you compare the OCT sizing in the phantom models, it's most accurate. Well, I was kind of oversizes by 8%, but OCT is absolutely gives you the perfect sizes which you need for stenting. Now, this brings me to the second part, which is post-Pci optimization, where we use OCT to pick up either medial dissection and position or stent expansion. Now, it's really important that you pick up these because they have direct link to the outcomes. This is an octogenarian who was waiting for a CABG in the ward, and he suddenly became unstable. As you can see, there is dye holdup in the aorta. He had severe TVD and he had developed severe chest pain with hypotension. So we rushed him to the lab, and about 50 ml of contrast, we just went ahead and stented the lady to left main. He had tight left main disease, so we just put stents at random, and we just brought him back. As you can see, there is considerable LV dysfunction, which you can appreciate on this frame. And we brought him back. When he brought him back, one of my colleagues said that everything looks okay, even though there is some RCA filling. He says that there is no need to optimize the LAD left main stent. Everything looks okay, but I insisted. We did an OCT run, and on the OCT run, if you can see, appreciate here, there is considerable stent under expansion. In addition, we also put up a huge dissection. These are the overlapping stent segment which are considerably under expanded. And there was also presence of a prolapse, plaque prolapse, which is essentially red thrombus, because as I told you, while waiting for his turn for surgery, he had developed a plaque rupture, which in a disease segment led to complete occlusion of the vessel and him becoming unstable. So we stented the intervening segment between distal left main, and we optimized this with high pressure balloons. And we finally did an OCT, and as you can now see, the stents are very well expanded in all the segments, the overlapping segments, and there was considerable gain in the lumen, which probably will translate into good results on follow-up. Well, most importantly, OCT also tells you as to where you are going wrong, and I'll show you certain examples. In this case, we had opened a CTO of LAD. The RCA was fine. There was some distal filling. And if you can appreciate here, there was a huge diagonal and a big septal coming out, but we worked really hard and we somehow got into the distal vessel with the Gaia wire, and the vessel was stented. And we thought we've done a good result by implanting a 2.75/28 and a 315 drug-eluting stent. We had to do the FFR for the RCA, which turned out to be negative, and this was part of a workshop, and we had people, and to our surprise, we noticed that yes, the CTO which was opened, and we were trying to kind of tell others that we opened a difficult CTO, had completely closed down. So it was most embarrassing. So intervention is a very humbling experience, and we wanted to really know Now, we did the OC for this patient, and what we noticed that there was a lot of thrombus, and you can see thrombus, which was a thrombus-filled vessel. We had to progressively dilate this. And what we noticed was there was considerable malopposition. You can see the stents are floating. There was underexpansion. And most importantly, the major contributor was a proximal edge dissection. We had not done the OCT at the time of acute while we were addressing the CTO. This was probably because we had used a lot of contrast, and I didn't want to add more contrast onto the segment. Now, these intervening segments which you're seeing, it's not that stent is not there. The stent is there, but OCT cannot pick up the stent because it is covered by thrombus. So we then went ahead and we did a lot of post-dilatation. We addressed the proximal segment with the additional small stent, and this was the final picture post-optimization. And now in the intervening segments, it's not that we've stented now. These stent struts are becoming visible because the thrombus is now gone, and we obtained a very optimal and a good result. Well, the second case was yet another CTO. This was the LAD CTO, which was addressed. He also had significant RCA disease, so we addressed first the LAD CTO. We implanted a stent, and which appeared pretty good to us. And then 5 days later, we brought him back. We addressed the RCA and we stented the RCA. It just occurred to one of my colleagues. He says that since you're in, why not check the LAD stent? And this is what we noticed. We noticed a kind of filling defect at the proximal part of the LAD stent, encroaching the distal left main. So there was a filling defect. So we decided to do the OCT, and when we did the OCT, we noticed that there was a thrombus in the proximal part of the stent, which was now moving towards the left main segment. So this is what it was. There was slight malposition there. There was red thrombus. This is the red thrombus, which is there in the proximal part. And this is what was the culprit. There was a dissection. There was a left main dissection while we were addressing the ostial segment of the LAD. There was a dissection in the left main which led to formation of a thrombus. So there was a geographical miss in this patient which led to thrombus formation in the proximal part. So we finally took a stent and we put a stent from left main to LAD, and this was the result post-optimization. This is the guide catheter which you're seeing. This is the LMCA stent, overlapping stent struts. And these are the cut sections of all the stented segment where the stent is very well opposed. a very common picture which you might have seen, and post PCI algorithm, it shows you very clearly. And there are certain cutoffs which I mentioned. I'm not going to go into the details of the cutoffs which you need, but yes, it gives you by definition whatever cutoffs which you need to have. Most importantly, the most important predictor of stent failure is the under expansion. So if it's a tapering vessel and a long stent which you put, you must divide the vessel into two parts, the proximal and distal, and have separate references for the proximal and distal part. And one must achieve more than 80% of stent expansion. The rest, you need to pick up the sections. It's the distal dissection, the distal vessel runoff, and plaque protrusion, malposition. All of them are important, but the most important is the under expansion, the distal edge dissection, and the MSA of less than 4.5 millimeters square. So if you keep only these three important facts in mind, you will end up having very good results, provided you avoided any geographical mismatch, malposition, tissue protrusions, or edge dissections. Well, to summarize, I would say that OCT guided precision PCI basically transforms the decision both pre and post intervention, and clinical studies have shown that they lead to additional interventions about 35% of patients, and with considerable reduction. Whatever you might do, at the end of the day, it should produce better clinical outcomes, and this is what has been shown in clinical trials, that if you transform your decision and you get good clinical outcomes, you are very happy. And yes, when we compare OCT and IVUS, OCT is 3 times more sensitive. It has about 10 times higher resolution. It gives you images at 20 times faster speed, and it is amazingly user-friendly. To conclude, I would say good imaging modality is the hinge on which correct decision-making is based. And in OCT, you have a tool for Pci optimization, because an ideal tool. Why? Because it's got a short learning curve. It's associated with less radiation exposure and procedure time. And these high-definition images, or the magnified images which it produces, it leads to better delineation of the plaque morphology. You accurately assess the size of the vessel, and which basically translates into precise stent positioning. And most importantly, you pick up the complications post stenting and address them in a manner which is which translates into good results. With this, I end my talk, and I thank you all for your patient learning. I would be happy to answer all your questions.
Thank you, Dr. Chadha, for such a illuminating lecture during the Diwali. This is full of lights, and I think you've lighted up many minds, particularly with your precision stenting guided by imaging. What I do is we'd ask a couple of more speakers to present their cases, and then we will take all the questions together, if that's okay with you, Dr. Chadha. So, Dr. Biswaranjan Jena is our next speaker.
Absolutely fine.
Dr. Biswaranjan Jena is our next speaker. Dr. Jena, he is senior consultant cardiologist of cath lab at Ashwini Hospital, Cuttack, which is also my alma mater. He's done his MD medicine and from VSS Medical College, Burla, and DM cardiology from CMC Vellore, from SCB Medical College, Cuttack. He's expert in angioplasty, coronary angioplasty, primary bifurcation, left main CTOs, and he's also done a lot of devices. So he's going to talk about a very important topic, the long segment CTO. So over to you, Dr. Biswaranjan Jena, for your case.
Dr. Jena, you need to unmute yourself, doctor.
Class 2, class 3 angina, normal renal function, and he had a good LV function in echo. So as we go through the angios, as you can see over here, these are the left system caudal views. Here we can see circ is almost okay, left main is okay, and LAD there is no significant lesion per se. And as you can see over here, there is some filling of RCA retrogradely from the left side. And moving on, the angiography, as you can see over here, here is the cranial views. As you can see that there is a retrograde filling. This is the PDA, this is the PLV, and the segment after that in the retrograde filling also it's looking somehow diseased. As you can see over here, it's a little more clear in this view. As you can see, these are the retrograde filling of PDA and PLV, and some that means the distal part of RCA filled retrogradely also, it shows some amount of disease. And going to the angio of RCA itself, there is a total 100% cutoff at the distal part. And as we go for the JCTO scoring thing, actually this angio is angio of RCA is showing that there is a blunt end of the segment. And though I have not taken the contralateral shoot in simultaneously with the antegrade shoot, but probably it's more than 20 millimeter of length. And if we actually in the bigger view, there are some calcium, as you can see in the LAD over here, there are some calcium in the LAD itself, though he is a 48-year-old, but he is a diabetic and of long duration, almost 8 years. And here there are some scattered calcium, one this side and that in the upper part of the segment. So this is the CTO. So as initially, I always go with a normal wear to see, means to have a feel of the lesion, whether I can slide over it. Sometimes the normal wear also can pass. But thing is that here it's a blunted segment, the chance is low. And the guide selection, as you can see here, I tried with the JR first, and with this Varcos wear, that is a BMW wear, I tried to have a feel of the lesion. Then, of course, I felt that I cannot cross with that BMW wear. So what I did, here is a over the wear balloon. It's a NC mini tray, and it's a 1.2 into 12 millimeter balloon. With that support, I went for the crossing of the lesion. There is not a good support from the RCA, means from the JR. But thing is that if I would have been trying a balloon anchoring technique or something, that conus artery, or there is no significant branch proximally over here where I can anchor the balloon. So I thought that okay, I will go ahead with this over the wire balloon, and this wire is a pilot wire. As you can see over here, if there is a secondary marker, it's a pilot wire, and with that, somehow after some manipulation, some sliding, means luckily I crossed the lesion. It took little time, but I crossed the lesion. Then what happened, that the same balloon I tried to negotiate over the wire, crossed wire, but it's not moving. Means it's a 1.2 millimeter balloon, but still it's not crossing the lesion, or the blunt part, it's not moving inside the lesion. I tried little hard, but with this much of support and all those things, somehow I didn't succeeded in crossing the balloon. Means wire is crossed, but balloon was not crossing, and it's a pilot 150 wire. Then I thought that okay, for the support thing, if I have crossed this lesion, I will do one thing. I will take another wire so that I can just slide if it is possible, so that I can slide the wire just opposite to the first wire, so that I can have a good support. And with that support, if I can cross the balloon, that other wire may act as a cutting balloon also. But somehow, this is a whisper wire, but as you can see, there is buckling of the wire, and it's not going beyond that occluded lesion. So with that, I have to change my strategy. And I thought that, okay, let's try with the same balloon, same over the wire balloon, whether with little support the wire can move or not. But still with that balloon support also, it's not moving. So after that, I tried once again with some intubation, deep intubation of the guide, and I tried to manipulate that same 1.2 millimeter of over the wire balloon to cross the lesion. But as you can see, I was not successful with that. After repeatedly trying, somehow now, as you can see, it has crossed that lesion part, and I started dilating it gradually. The balloon was somehow after some dilation, the balloon started moving up. There was some resistance. Definitely there was resistance, but I succeeded with crossing the balloon. Then with that same balloon, dilation was done, pre-dilation was done. But after that, here you can see that with that balloon, I gradually I can go beyond this occluded segment, and I am inside the lesion. Inside the lesion, dilation was done. This is a 1.2 millimeter balloon. After that, I thought, okay, with 1.5 millimeter balloon, I will try. So once I had done it with 1.2 millimeter balloon, if luckily it can go through. But somehow, as you can see over here, whenever I am crossing, I am trying to negotiate the balloon, the support is not there, the guide support is not there. Repeated pushing and all little deep intubation maneuver, it was, this is not giving up, means it is not going beyond certain point in the lesion. So at this time, there was, I should have used a guideliner or something, but there was some issue of finance, all those things. But I thought that, okay, I will try. If I am not successful, then I will somehow go with some guide extension in the form of either guideliner. So after repeated manipulation, I was able to cross that balloon also, that 1.5 millimeter balloon. And after pre-dilation, this is the lesion where we can see there is some calcium with fibrous tissue over there, and it's around 20 to 25 millimeter of lesion. Here we can see that after opening this, PLV is okay, PDA in the ostium also there is some disease, and this is also a diseased artery in the osteoproximal part. After that, things are little easy. I went with 2.5 millimeter of NC balloon and done serial pre-dilation of the total lesion length. Then after NC dilation, still there is some lesion over here. I want to, then I have taken a 2.75 millimeter N balloon. I have pre-dilated with just nominal like 12 millimeter of mercury and 12 atmospheric pressure. Then this is the lesion. It's not, it's somehow it's fibrotic and little calcified. So after dilation also, it's not gaining in lumen, but I thought that, okay, with that fill, I will go with the stent itself. And this is the stent, 2.5 millimeter into 32 millimeter of drug-eluting stent. Stent went without any hindrance, and after that, this is the positioning going on. Then this is the stent inflation. As you can see that the stent is opening fairly well. Then I have done serial post dilation with a 2.5 millimeter NC, and after that the proximal part, means before bifurcation, with 2.75, 14 millimeter of 14 atmospheric pressure. And after post dilation, serial post dilation, this is the final result. So sometimes hardware what you want to get, it's little difficult, but in this case we managed with whatever is available over there. So thank you. If any questions.
Thank you, Dr. Jena, for your wonderful case. This is a pretty important case, I would say, because CTOs are which we do on a daily basis, This is something which will require a lot of operator experience, a lot of hardware, techniques which are involved. So we will go to the third case, and after that we will have a combined discussion for the three cases. I would like to invite Dr. Dibya Ranjan Behera, KIMS Hospital, Bhubaneswar. He's done his DM cardiology and preceptorship in interventional cardiology from Cleveland Clinic, USA. And he was assistant professor of CMC Bangalore till 2019 August. He is winner of Indian Heart Journal A.B. Gandhi Award for Excellence in Cardiology for the year 2017. He has posters and publications in different symposias. He's expert in doing complex coronary angioplasties, has performed renal and peripheral angioplasties as well. So Dr. Behera, he's going to present a case of non-STEMI with double vessel disease. Over to you, Dr. Behera.
Very good evening to all of you and happy Diwali. Binayak sir and Chadha sir and all my co-mentors. So this is very nice evening, and already I am very much enlightened by presentation from Binayak sir and Chadha sir. So okay, let's begin my presentation. Is my slides visible, sir?
Yes, it is visible.
And I'm audible? Yes, sir.
Yes, you are audible as well.
Okay, sir. Thank you. So this is a case of NSTEMI with double vessel disease. So this is the story of a 56-year-old male who is come to AIIMS Bhubaneswar with chief complaints of chest pain, and we found out that he is in acute coronary syndrome, NST elevation MI. Echo was normal. There is no RWMA. He is in sinus rhythm and class 2 angina. He is hypertensive. He is not diabetic, and he was not in heart failure. So this is his angiogram. You can see that there is left main is dividing into left antedescending and left circumflex, and LAD has a lesion here, and the proximal LAD at the time bifurcation of the diagonal, it is made in a class 1-1-1, and circumflex has a minor lesion, but the RCA is filling retrogradely, so probably that RCA may be having a CTO. This is in other views, the iliocranial view, and this is in caudal view. So this is other views, and when you see the RCA, that RCA has multiple tandem lesions of around 90% stenosis, and ultimately at the point of distal RCA, it is kind of CTO with no integrated filling, so that we expected from the left-sided angiograms. So this is in PA cranial view RCA. You can see that multiple tandem lesions with a complete total occlusion in the distal RCA. So this is, if you ignore the minor circumflex double vessel disease, we calculated this intact score, it is around 20. But we planned better is CABG, and we informed the patient, but they were not willing for CABG. So, and considering also the intact score of 20, so PCI is also an equally good option. So we planned multivessel PCI in this patient. So as Chadha sir already enlightened, and Dev sir, so this is we planned, okay, this LAD is an important vessel, so we should go ahead with some imaging. So we arranged IBUS for this patient, and we planned an IBUS guided PCI to LAD. So first we wired the LAD, then we did an IBUS run. So as so this is needless to mention now, already been enlightened. So how this imaging help? It is in pre-procedure, also post pre-procedure planning, like in access plaque vulnerability, what is the functional significance, what are the reference segment diameters, and what is the length. and also to confirm the landing zone. For post-procedure, whether the stent is expanded or not, it is opposed or mal-opposed, is there any tissue protrusion, is there any dissections. So all those things is very, very important for the long-term as well as short-term stent longevity as well as patient clinical profile. And also in follow-up, whether there is stent restenosis or thrombosis. So with that note, this is the IVUS. So from distal LED, we are running the IVUS. You can see distal vessels. This is the vessel, and this is the narrowed segment. There are some calcifications you can see here. And then this is the diagonal joining. That is the narrowest at this point. And this is the proximal LED, which is a little tactic. And you can see the SARC joining now. SARC osteum is disease free. And and distal, this is the left, okay, this is the left main, which is disease free. So when you go to the measurements, the proximal, there is some plaque burden of around 30%, but the overall area is around 19 millimeters square. So it is good. And this if you consider from this to this point, this is around 4.2 and 3.2 diameter. In the narrowed segment, there is some calcification. You can see that, and the diameter here is 2.1 millimeter. And at the distal landing zone, there is a diameter of 3 millimeter. So with this in mind, we first pre-dilated with 2.5 NC, then we put a 3.5 into 33 millimeter drug-eluting stent and deployed at 12 atmosphere. And post-deployment, we did post-dilatation with 3.5 balloon. That balloon was difficult to track, so we put a second wire for the body wire technique, and the balloon tracked. Then we dilated with 3.5 balloon from 12 atmosphere to 20 atmosphere. So this is the angiogram post, and then we did an IVUS run. So you can see here there is the SARC osteum is absolutely free, and stent looks well opposed. There is no dissection, and TIMI3 flow in SARC. So this is the IVUS run post procedure. You can see distally there is no stent, no edge dissection. Stent is well opposed. This is the diagonal stem joining. But as we know proximally, we think there is some stent under expansion. But the SARC osteum was okay, as the area of polygon was okay, and left main was okay. There is no dissection. Proximal as well as distal, there is no dissection, but we thought we'll still post dilate more because of little under expansion at the proximal edge of the stent. So that's why again post dilated with 4.5 into 8 millimeter balloon at the only proximal edge of the stent, and again did an IVUS. So there was no distal edge dissection. Stent is well opposed. There is no tissue protrusion. And this is the diagonal osteum, which looks good. Then at the proximal edge, the stent looks well opposed. This is the proximal edge, and this is the sarcostem. So there is no overhanging of the stent into the sarcostem, and left main is okay, no dissection. So we are happy with this result, and this is the final angiogram. So though distally there is some hump is there, but by IVUS imaging 2-3 runs there is nothing. But that we noticed a sort maybe some thrombus migration, but we are doing with proper ACT monitoring half an hourly, and we keep our ACT more than 300 to 350. But still then some minor thrombus is there, but there is this is maybe some wear related issue, but we have never reached to that point. So we observe this patient, there was no pericardial effusion or anything, and the flow is okay, TME3 flow. So this is the pre and post OCT images. This is the pre image. You can see that proximal there is the area was 10.9 millimeter square. At the narrowest point it is 3.8 millimeter square, and distal is pre is 7.3 millimeter square. After post stenting and optimization, we achieved the proximal edge of 11.5 millimeter square. At the narrowest point, we get a 7.0 millimeter square, and distal end 7.8 millimeter square with no edge dissection at any point. And we are happy with the result. And you can see here for proximal landing also how it helped. You can see this is the area of polygon, and this is the circumflex joining. So there is no stent visible here. So this stent is absolutely, there is no strut across the left main circumflex. This is just landed just very much proximal to the LAD ostium. Then after PCI to LAD, we think we'll go ahead with the PCI to RCA. So this patient was stabilized, his creatinine was normal, and so we have taken this patient for PCI to RCA after 7 days. So this RCA is a multiple tandem region with distal CTO. So we did a contralateral shoot to know the exact CTO length and all. So initially put the JR6 guide and a diagnostic JL catheter in the left LMCA, and what he found that up to the this distal CTO segment, I took a fielder FC wire which went easily, but after that there is some resistance. So if you calculate the JCTO score, it has a tapered end, there is no calcification, there is no bending, and the occluded length is, I think it is less than 20 millimeters. So, and it is a fresh lesion. So, I thought it is a easy, as per the JCTO score, it is not a very difficult CTO. But the only thing is to puncture the distal cap, which looks tight, which feels tight by the fielder FC wire. So I exchanged the wire and took a microcatheter, Corsair, and I took Gaia 3. I don't have Gaia 2 at that time, so I took a Gaia 3 wire and tried to cross to the distal lumen with contralateral injections. So here you can see that I am just at the distal point, and that point I have to enter. So I am just at the distal point then. So here with repeated manipulation and this thing, finally I was successful to enter into the distal lumen. Then I exchanged the wire to a routine wire, cyan blue, and with 2 balloon dilated the whole segment of the RCA. Then distally put a 2.5 into 48 millimeter drug-eluting stent. Then dilated with the same stent, just keeping it a little proximally. Then in the mid RCA, there is I put a 3 into 38 millimeter drug-eluting stent, and the proximal osteoproximal RCA 3.5 into 22 millimeter drug-eluting stent. So then serial post-dilatation done with the 3 to 3.5 millimeter balloon. So this is the final result I got. So take-home message from this case was multivessel PCI is a feasible option, but we have to calculate the syntax score. We have to see the present profile whether it is diabetic or not. And if at all we are taking for a multivessel PCI, it should be proper planned, and we should do staging procedures, if, particularly if CTOs are available in that case. And imaging is the cornerstone of any intervention. And imaging helps in proper stent placement, whether it is opposed, how much MLA we have achieved, is there calcification, if there is significant calcification, we have to take additional tools, and also to know whether stenting dissection is there or not. So imaging is the cornerstone for long-term PCI patient's profile and PCI success. So with this, thank you very much. I'll be very happy if you have some questions. Thank you.
Thank you, Dr. Behera, for your excellent presentation. I must say, I think Dr. Chadha will actually agree with me that at the stage of the intervention where you are, Dr. Behera, Dr. Biswaranjan, we would actually never contemplate of doing these kind of complex angioplasties at this stage of our career. But the way things stand now, these are kind of the bread and butter angioplasties today, and it's good to see and encouraging. It's a very encouraging that young interventionists like you actually are believing in the imaging, which is an excellent way to go. So may I start with some questions with maybe Dr. Chadha's presentation? I wanted to ask you that do you think that in imaging modality, the IVUS and the OCT, are they competitive or are they complementary? That's question number one. And question number two, do you think there is any limitations in the OCTs for left main, CTOs, and when you are actually dissection plane?
Okay, thank you, Dr. Prabal. Very good questions. At the outset, I would say that IVUS and OCT are complementary. They are not, kind of competitive. We must remember that IVUS showed the path on which OCT is treading. There are certain issues I will highlight both the positive and negative of both the imaging modalities. IVUS has a little bit of learning curve. So you need to do about 10-15 cases along with a proctor. But the HD IVUS which is available, maybe 4-5 cases are good enough for you to learn and to pick up. The reason for this is that, it's like I always give this example. It's like getting into a room with a sonar in hand and then kind of reconstructing and saying that, okay, there is a table and there is a chair in this room. And now getting into the room with a torch in hand, you say that, okay, there is a table, chair, and in addition, there are 2 books which are lying on top of that table. So that is the difference between a light-based and a sound wave-based technology. So it magnifies, shows you good details OCT. But having said that, IVUS scores over OCT in patients with LV dysfunction, in patients where contrast usage is limited, in patients with osteal diseases, which could be both RCA and the left main, and in patients where you are kind of basing your intervention on assessing the plaque, quantum of plaque which is there in the vessel. So that OCT will not be able to tell you, because the OCT is limited by its penetrability, which is about 3 millimeters or so. So OCT will not be able to tell you as to what is the extent of plaque distribution, which IVUS will completely tell you, because it has got penetrability of about 10 millimeters or so. IVUS also scores over OCT in CTO lesions, because these are chronically underfilled vessels where it becomes very, difficult to assess the true vessel size and dimension, where IVUS scores over it. Having said that, where does OCT score over IVUS? Very user-friendly. It gives you magnified images of the vessel wall, and there is a very short learning curve. You do 1 or 2 cases and you are on board. The other distinct advantage of OCT is its capability of picking up post-PCI complications where IVUS is slightly difficult, which I will tell you comparing different things. If the sensitivity of IVUS on plaque prolapse is around 40 to 50%, whereas OCT is about 80 to 90%. IVUS certainly is going to miss out on minor dissections, which OCT will definitely pick up. Malapposition again is a problem, but under expansion, yes, IVUS picks up under expansion as good as OCT. The other advantage of OCT is the magnified images. As I told you in my talk also, it gives you 20 times or 10 to 20 times more magnified images. So when I'm doing bifurcation and I have to really study which struct my wire has gone through, OCT is incomparable. You just can't compare OCT and IVUS in these settings. Third thing is we see a lot of calcified lesions. Dr. Debashi's case, I think he is, I must appreciate. He's done a nice complex case, but he was very generous in making it syntax, in giving a syntax score of 20. Debashish, I think it is close to 26, 28 or 30. You've done a much more complex case than what you have told us about. But yes, there was a lot of calcium in your case, and there was circumferential calcium in locations I could see, and 180 degree was there. Now, what happens in such situations is IVUS just gives you a rim of calcium which you can see, but the thickness and the volume of distribution only OCT will tell you. So to strategize whether you need what kind of atherectomy tool will be required is essentially dictated by the thickness, and we have a CVI score, which I think of you all will be aware, which primarily uses the rule of 5. That means thickness more than 0.5, the length more than 5 millimeters, and occupying more than about 180 degrees of the circumferential arc. So, I mean, this you can use only OCT to, stratify your lesions. So, in nutshell, they both complement each other. In my talk also, I just made a remark that the results are based on a good imaging modality. So it is not that one is superior to the other. OCT has been riding on the back of IVUS because IVUS was IVUS paved the path on which OCT is not now riding. Yes, there are certain advantages, and the contrast clearing is definitely required with OCT, and a lot of people make this as a negative, but I tell you what, I often say this, and I've demonstrated in a couple of live cases, that you don't have to think too much about contrast clearance and acquiring images with OCT. I have done left mains with 40-50 ml of contrast because you don't need to check in different views. You take a nice view of 10 ml or 12 ml contrast, and you get everything about that lesion, in terms of length, the diameters, the plaque morphology, and you can immediately decide what are the tools which you're going to use, where your stent is going to start and where it's going to end. So, I mean, contrast, even though we say that it's a big negative, but no, contrast is a big you save contrast when you use OCT. You must keep that in mind. But yes, contrast definitely is required. And with borderline renal dysfunction, I would certainly use IVUS and not OCT. So this, in a nutshell, I would say that the answer to, even though it's been a very long answer, but I would say that they both complement each other. And we must judiciously use both the modalities to, produce good end results, so that what looks angiographically good should stay like this at the end of 6-9 months or 1 or 2 years, because on the table everything looks good, but at the end of 3 or 6 months when the patient comes back, and then when we see the results, then we kind of introspect, yes, I could have done this, and next case I would like to do that. So that is very important. And Dr. Prabal, I've forgotten the next question which you asked while answering this.
Yeah, we're talking about the dissection. I mean, when you're actually dealing with dissections, pushing dye, whether it causes during OCTs, does it cause the increase of the dissection plane?
Now, this is, I will tell you. Where dissections are concerned, and yet another important question. Now, dissections can happen in the proximal end of the stent or the distal end of the stent. And now what we've learned from my Lumen 3 is that proximal dissections are not very important. They can be left alone. Now, first of all, I must say, what is a significant dissection? A significant dissection is one which extends till the media. That is one. Two, the longitudinal extent of this dissection is around 2 millimeters or so. And three, if I make an arc, then if it occupies more than 60-degree arc, these are by definition on imaging significant dissections. That means extending to media, longitudinal extent of 2 millimeters and occupying more than 60 degrees of arc. Proximal, if you see a huge dissection, you can still forego and address, you might skip to address this because it will not propagate. And if it is not going till media, you can leave it because the chances of thrombus formation are less. Distal dissection, since the vessels normally taper down, so distal dissections are to be addressed. If they have any of these attributes. Number two, when you notice a dissection and you don't have an imaging modality, you need not, one is that you not pick up because the sensitivity of angiogram is poor, but any angiographically visible distal dissection has to be addressed. You cannot leave it because it will become nidus for thrombus formation and you can have stent failure because of this dissection. So treat dissections if you have imaging tools available, if they extend to media, if they occupy more than 60 degrees of arc, and if the longitudinal extent is more than 2 millimeters. And treat dissections angiographically if they produce a filling defect, which you can appreciate on screen. Distal dissections more important than the proximal dissections.
Thank you, Dr. Chadha. Biswaranjan, do you have any questions for Dr. Chadha? You please unmute, please.
That last part only means because I worked somewhere there was imaging, now I work somewhere there is no imaging. But thing is that I was asking about that dissection only. What should be the criteria in angiography that distal dissection particularly for acute stent thrombosis and stent failure? So if it is visible, means we should treat. So
so invariably you have to take complementary views, Dr. Biswaranjan. You know, if you are working in AP, you have to go to a 90 degrees, and then get in that. So.
No, sometimes what happens that we say that there is some dissection but not that apparent and there was no flow limitation. So we usually think that whether to put another metal or not. But
this is a dilemma which one goes through, and I would tell you that there are financial limitations with imaging, and I quite agree. Not all centers can have it, but yes, you certainly sleep well when you've seen what you've done with the patient, because otherwise you keep going through that same point. Oh, what if he comes back? And moment the phone rings, you have a feeling, okay, the call must be for this particular patient because I think I left the dissection there. So we've all gone through this cycle. So, and that is what it is.
That's exactly what it is. What we'll do is we'll have a couple of more clinical cases by Dr. Ritesh Kumar and Dr. Varun Kumar, and then we will have a final discussion with all the 5 cases. So Dr. Ritesh Kumar, if you're ready, we can start with your case. So let me introduce Dr. Ritesh Kumar. He is Senior Interventional Cardiologist at Alam Hospital, Ranchi, and he has done his DM Cardiology from LPS Institute of Cardiology, Kanpur. He has experience of working in cath lab for more than 18 years. He has been doing routine angiography, PCI, primary PCIs, pacemakers, ICDs independently for more than 10 years. And he has been the first person to do primary PCI, PBMB in Uttarakhand. And that's an amazing, definitely skill to have, to be the first to do something. So he's going to talk about a case of stent thrombosis in COVID era, which is so very important and so very pertinent in this time. So over to you, Dr. Ritesh Kumar.
Yeah, good evening, everybody. It has been a wonderful evening. I would like to go straight to my case. Okay. Now it's visible.
Yeah, we can see you and hear you also.
Yeah. My case is a 45-year-old lady. She is a diabetic and she came to me with acute chest pain for 5 hours with a body weight of 50 kg. Her ECG showed ST elevation in inferior leads and reciprocal ST depression in precordial leads. And echocardiogram showed hypokinetic inferior valve with a EF of 45%. So with the diagnosis of acute inferior valve MI, the patient was taken to cath lab with a loading dose of 300 mg of aspirin and 180 mg of ticagrelor. Her coronary angiogram showed a normal left main coronary artery, 50% lesion of the mid-LAD, normal non-dominant left circumflex, and 95% stenosis of proximal RCA with thrombus. So she was started with the maintenance dose of tyrosine also, for that was continued for 12 hours, and PCI to RCA was done with a drug-eluting stent of 3 into 18 millimeter. So this is the angiogram. This is the left system that showed some plaquing of the mid LAD and normal LCX. And this was the right coronary angiogram that shows some ulcerated lesion with thrombus in the proximal to mid segment of RCA tortuous vessel. And then the lesion was tackled and a drug-eluting stent of 3 into 18 millimeter was deployed. And this stent was post-dilated as well with 3 into 8 millimeter of balloon, non-compliant balloon. And this was the final result. On a second day of procedure, her RT-PCR report for COVID-19 test came out to be positive, and she was shifted to COVID ICU and managed accordingly. I personally ensured that she should take the dual antiplatelet treatment, and she was also given some antiviral drug like favipiravir and some ivermectin and doxycycline as well. Her further course was uneventful in the hospital, and she was discharged from the hospital on 7th day with a dual antiplatelet treatment of aspirin 75 mg once daily and ticagrelor 90 mg twice daily with other medicines for diabetes and zinc and vitamin C and all. On 10th day of her discharge, that was 17th day after the index procedure, she presented again with a continuous chest pain and sweating. Her ECG showed re-elevation of ST segment in lead through 3 and AVF. With obvious diagnosis of subacute stent thrombosis, patient was taken to cath lab and an angiogram was done that showed total occlusion of the RCA at the proximal part of the stent. So this was the angiogram that showed the totally occluded stent. It was rewired, and after repeated passage of export catheter and thrombus aspiration, this was the picture. So we decided to put another stent and a longer stent of 3 into 23 millimeter drug-eluting stent. This was deployed, and this was the final result. This was the ECG when the patient came for the second time with a re-elevation of ST segment in inferior leads, and this was the ECG after rescue PCI. So the learning point in this case is acute and subacute stent thrombosis is a rare incidence of less than 1% at 30 days, but serious complication of primary PCI with stenting and is associated with extremely poor outcome if left untreated. COVID-19 infection is associated with a hypercoagulable state with a high incidence of thrombotic complications, including stent thrombosis. The major factors for acute or subacute thrombosis, we all know, are coronary intervention technical failure, decreased platelet inhibition either in the form of drug hyporesponse or poor compliance, and hypercoagulable states. In this patient, although no intravascular imaging was done after stenting, the angiographic results in orthogonal views were satisfactory, and there was no evidence indicative of technical failure of the procedure. As patient was on ticagrelor and drug compliance was also ensured, there were less chances of decreased platelet inhibition. Therefore, COVID-19 triggered hypercoagulability was believed to be the more likely cause for subacute stent thrombosis in this patient. Patient was again continued for 12 hours of continuous tiotropium infusion. She was put on a triple therapy with aspirin, clopidogrel, and dabigatran. Aspirin and prasugrel could have been an option, but she was underweight for that. Her body weight was just 50 kg. She was discharged on the 7th day after procedure in hemodynamically stable state with LV ejection fraction of almost 42%. That's all about my case. Thank you, and happy Diwali to everybody.
Thank you, Dr. Ritesh Kumar, for your wonderful and very important case. We'll come back to you for a discussion. Let me finish our presentation first with Dr. Varun Kumar. Welcome, Dr. Varun Kumar. Let me introduce him. He is the head of the Department of Cardiology at Oct Medical Center, Ranchi. He's done his DM Cardiology from LPS Cardiology, Kanpur. He's a IFE Fellow of European Society of Cardiology, an expert in doing complex coronary angioplasties, and has performed renal and peripheral angioplasties as well. He is specialized in single and dual chamber pacemakers and has expertise in performing BMV and device closures like PDAs, AFC, and BAVs. So he's going to talk to us on an unusual complication of bifurcation stenting. Since he has hands-on experience on IVUS, FFR, and rotablation, I'm sure he must have done a terrific job. So, Dr. Varun Kumar, over to you.
Thank you, sir.
Please unmute yourself, Dr. Kumar. Please unmute yourself, Dr. Varun Kumar. Yeah.
Yeah, very happy Diwali to everybody, and good evening to everybody. And I just want to share my case, which is quite interesting in the sense this patient was also COVID positive, and he was admitted to some other hospital with COVID, and during hospital admission, he developed acute enterorectal MI. Am I audible?
You're audible, but we can't hear your screen.
Dr. Varun Kumar, you need to share your screen, doctor.
Hello.
Doctor, come back to the browser. You need to share your screen. Your screen is not visible.
Hello. Yeah. Am I audible?
Doctor, you are audible, but we need to share the screen at first.
Just a minute. I think there are some issues.
Doctor, give a click on share screen.
Yeah, actually it's not highlighting, so unable to press it.
Doctor, there is a big rectangular box of your own screen in there. Select that. The share button will turn blue then.
Just a minute, sir.
So there is a big rectangular box of your own screen. You have to select that. The share button, until and unless you don't select.
Not highlighted. So it is not getting connected. Actually.
You are able to see your entire screen in front of you now. That option of your entire screen.
Yeah, I am seeing you, but not none of you are visible to me. Just a minute, sir. Okay.
Yes, Dr. Varun Kumar, your screen is shared now. Please open the presentation.
Just a minute. Okay, now it is visible.
Yes, doctor, it is visible. Please, we can continue now.
Okay, thank you, sir. So, this patient came from another hospital where he was admitted with a COVID-19 pneumonia and was undergoing treatment for that. And during the hospital stay, he developed acute ventricular MI where he was managed conservatively. And when he became COVID-19 negative, he came to me for his cardiac problem. So, this is a 48-year-old male, newly diagnosed diabetic and non-hypertensive. There is no such a past history, and I said he was admitted with COVID-19 pneumonia, where he developed respiratory MI, went into congestive failure, and developed cardiac shock also. After he became negative, COVID-19 negative, he came to my hospital and we did the echocardiography and found that his heredity was severely hypokinetic with ejection fraction around 30%. CT thorax showed bilateral extensive infiltrates. So, in the hospital, at the other hospital, whether he was admitted, he was managed with enoxaparin and antiplatelets. He was not thrombolized there even. And so when he came to my hospital, after stabilization of the patient, I did the angiography and it showed a triple vessel disease. And there was a bifurcation lesion in the mid LAD, Medina 1 lesion, which 99% is in both the D1 and LAD with large thrombus in the mid LAD. Mid RC has a discrete 80% lesion and the distal LCS has a discrete 90% stenosis. So I planned for a bifurcation stenting of LAD and D1 with a tap technique, and later on when the patient gets stabilized, I planned for a Pci for LCS and RCA. So this was his CT thorax. You can see the extensive infiltrates and pneumonia on the both sides of lungs post-COVID. So it was better for this patient to go for a angioplasty rather than a EMG because of that pneumonia definitely bringing the patient from the ventilator would have been very difficult because of the extensive lesion. So I decided to go for the bifurcation stenting of LAD and later on the PCI of LCS and RCA.
I think Dr. Varun is frozen. Someone has to call him.
I think Dr. Varun Kumar is disconnected.
Okay. So what we can do is we can start off with some discussion while we wait for Dr. Varun Kumar to come back. So Dr. Biswaranjan, I think we can start off with your case. So yours was a CTO case. So Dr. Chadha, would you want to start off with some discussion with Dr. Biswaranjan's case, which was a case of RCA CTO?
No. So I think that was a nice case, Dr. Biswaranjan. And the one message which that case, I think, gives to all of us all is the guide support. So I personally choose when I do such cases and I see that there is a distal CTO, I always use a good guide support. So I have an inclination of using amplats. So, that would have solved all your struggle because it was just the lack of guide support which made things difficult. Because your wiring was pretty easy, you could easily manipulate pilot 150 with the balloon support. So I think one feels very disappointed that I've crossed a CTO lesion and now my hardware is not going through. And you even tried to put a buddy wire. And if there's some background noise coming from somewhere, if it can be muted. Am I audible?
Yes, you are, Dr. Chadha.
Okay.
Yeah.
All right. So now it's much better. It's now much better. So I feel that case basically exemplifies a good guide support. And the other important thing which I would like to highlight when you're dealing with CTOs of RCA segment are that RCA is one vessel where there is not much of taper compared to the other vessel. So if there are no big RV branches coming out, your proximal vessel diameter is equal to the distal vessel diameter, provided you are not ending your stent in either PD or PLV. Because the bifurcation occurs at PD PLV, there the diameter reduction, we apply the Finet's law there. So if you're parking your stent anything proximal to that, you don't need to, taper your stents off in a big way. And even if you put a stent into either PD or PLV, you can use larger high pressure balloons. So that is another. But a very good case, and I think you persevered and you produced very good results. So I really enjoyed the case. Thank you.
Just to add on to Dr. Chadha's concern about the guide catheter support, we have seen many times that when you have a floating guide catheter on the ostium, it can cause a dissection without actually knowing it. So you might have actually finished off with a very, very good result of the CTO down below and possibly have sudden acute occlusion and then thinking what happened. So that is one thing definitely, as Dr. Chadha mentioned, that the guide cat support is probably one of the biggest issue when you are dealing with a CTO, because that's what will give you the base to actually do the whole case. I think it was a very well done case with the limitations which you have. And the other thing which I wanted to mention is that when you are doing a CTO, I think we need to be very, very clear with the patient's family that, the constraints of the finances should not actually overrule the science. Because at the end of the day, the patient's relations would want actually a good result at the end of the day. And it is very, very difficult to give a good result when it's a CTO without all the support which you have today. So we require multiple wires, you require catheters, we require microcatheters. So these are the things I think we need to kind of explain to the patients and the family while you are doing the CTO. It is better always, I feel, that to postpone the whole case if required be until we have the adequate support of all the hardware. So a good operator is actually a good operator when he is actually supported by all the the guide wires and the balloons and the support which he has. So that's one of the things which I wanted to mention. Otherwise, it's a very, very good case. And I'm sure that the experience of the imaging which you have acquired from the previous hospital, you can actually convince your owners of this current hospital to ensure that that you require an imaging modality for PCI. That's what I wanted to say. Dr. Varun Kumar, have you been able to come around?
He's still trying to log in.
Yeah, there is some bandwidth issue.
Sure. Can I add something?
Yeah.
I have also a couple of experience of operating CTO where the wire is not negotiating, and I was tempted to use balloon, and over the balloon I negotiated with the wire. But a couple of times it happened with me that I have perforated, and sometimes I have passed in the false passage. So with the balloon, there is a fair possibility that we can land it in the false passage. So like in your case, sir, when you cross the wire and the balloon was not going, at that time you should have checked from the controller side that whether you are in true lumen or it's gone in the false passage or somewhere else. That I pointed out.
Okay, can we go on to our next case by Dr. Jena? So yours was, sorry, by Dr. Behera. Dr. Behera, you done a DVD and which Dr. Chadha mentioned about the syntax score, which I also agree with him. that it was probably more than 20. It was definitely a much more complicated case, complex case, I would say, than what you presented, but you have done it very well. The other thing I always mention that when a patient refuses CABG, we need a heart care team approach. I mean, that's something which we always take into account in these medical legal atmosphere. So I'm sure that your surgical team was also in concurrence with what you have done. So any questions, Dr. Chadha, about Dr.
CABG?
No, I think it was a well-done case, and the only important point I would like to mention is that it's just a comment. It's just a comment, and it's in relation to multivessel PCI, where you are addressing the ostial LAD, and you have doubts about the plaque distribution in the circumflex. Now, imaging studies have very clearly shown that if you have an ostial LAD disease, only 10% of these patients will have plaque confined to the LAD. 90% of them will have plaque extending onto the left main. And it was very clearly seen on Dr. Behera's case when the OCT IVUS pullback was there was considerable plaque burden in the distal left main. So that is point number one. So if you are contemplating of just finishing at the ostium of the LAD, if you have imaging, it is always better to extend the stent onto the left main, because you will have a geographical mismatch, and which will translate into poor result at a later date. That is point number one. Point number two is when we do imaging and we are concerned about the side branch, then there are two important things. Because of paucity of time in imaging section, I did not include that. You have to look at the plaque burden. So it is not the ostium of the circumflex if it is clear or not. What we are more concerned is what is the plaque distribution on the opposite wall of the origin of circumflex, because if there is a thick plaque opposite the origin of the circumflex, you have more chances of this plaque moving from this side to the circosteum. So this is very important. If there is a calcium or a thick plaque opposite the origin of circosteum, there are more chances of, number one, either a cranial shift or plaque shift. So while assessing the side branch, we are more concerned about the plaque or the plaque morphology, the quantum, and its distribution opposite the origin of the side branch. Correct. So I mean, overall, a very good case and well done. Even though in RCA, I would have been happier had you addressed the PDA. Your wire initially was in PDA, but by the time you finished the results, it was in PLV, and you stented straight across the PDA because there was some amount of plaque shift into the PDA. So,
it always gone to
okay. Yes. So because of the images I couldn't, but you must try and catch, because see, between the two, whichever is bigger, you should try and hold that as the branch. And maybe,
yes, sir, yes, sir. But after that PDA,
okay, no problems. I mean, overall a good result. And same point, I'd like to emphasize that in RCA, PDA, PLV are important branches. In RCA, there is no generally taper of vessel, so stent choices have to be, it have to be uniformly high. In your case, you had 2.5, 3, 3.5. You could have used the 3 and blown it up to 3.5 proximally with one diameter. So, I mean, these are finer things, but a very well done case and very educative and lots of points to learn.
Thank you, Dr. Chadha, for your kind words.
Thank you very much.
We can go over to Dr. Ritesh Kumar's case. Dr. Biswaranjan, do you want to make some comments on Dr. Kumar's case?
Yes, one of the thing is patient, actually I missed that initial part, but patient was discharged on aspirin and ticagrelor, but still he had acute stent thrombosis. Then the later part when we are prescribing, can we advise him for, I'm going to the pharmacology part, aspirin, clopidogrel and dabigatran. It should be, I think, if he was on ticagrelor, there are studies, I think you can combine ticagrelor with dabigatran, but aspirin, clopidogrel and ticagrelor as triple antiplatelet therapy means can we use like that?
Exactly. I have put the patient on aspirin, clopidogrel and dabigatran.
So can we can we use all the three? Means as a trip, means combining a antithrom means direct thrombin inhibitor dabigatran with aspirin and clopidogrel.
You mean to say I should add ticagrelor as well?
No. What I mean to say that, okay, one antiplatelet with...
So what Dr. Debashish is trying to tell Ritesh is that generally when we use a triple therapy, conventionally we use vitamin K antagonist along with ecosprin and clopid.
Yeah.
So there are very few studies and with very small number of patients where DOACs have been combined with ticagrelor because the risk of bleeding is very high, both very potent agents. So they in what trials we had, there's a very small subset of patients wherein we still have not garnered the confidence of combining either ticagrelor or prasugrel with DOAC. That is what he's trying to say. And if you use triple therapy, conventionally all the guidelines, whether the European American guidelines, they advocate vitamin K antagonists along with ecosprin clopid. And then you, over a period of time, start knocking off the antiplatelets, and at the end of 6 months or 1 year, depending on, in an ACS situation, earlier the guidelines would say 1 year of therapy, and then you over only to vitamin K antagonist. Now there are studies which say that even 6 months of triple therapy is good enough, and then you can knock off the antiplatelets and continue the patient on single vitamin K antagonist.
Sir, I would like to ask one question to all our experts. Thing is that, sir, sometimes patient comes with a acute myocardial infarction, means STEMI, we do a plasty, then patient was intubated, patient was intubated, patient is not conscious. That time what happens that when we are prescribing aspirin and ticagrelor, suppose, sometimes I had a patient that with the right tube, means when they are giving, patient was intubated, patient was with ventilator, there was a right tube, and with that when we are using this aspirin and means ticagrelor, sometimes I feel that dose may not, means how we will manage that oral with oral antiplatelets at that somebody with large thrombus burden, primary you have done, intubated with all the supports and with a right tube to have give that aspirin and other antiplatelet. So I had a case, I thought that, okay, I have done good job with the RCA, patient was with temporary, patient was intubated, they had received CPR, but after that, on the third day, means of course there was no imaging, but on the third day or fourth day, he had a stent thrombosis. So how to manage those type of cases?
Okay. Can I address Dr. Deb?
Yes, Dr. Chadha, please.
Okay. See, stent thrombosis is a big nemesis, and it is multifactorial. It is multifactorial apart from, the technical factors. There are. I think I've had a couple of presentations, and maybe as we go on with these sessions, and maybe in the third or fourth, if I get a chance, I would like to share a complete talk, imaging-based talk on stent failure. The most important thing to remember, which is even applicable to Dr. Ritesh's case, is that you should try and identify the etiology of stent thrombosis. Where management, now let me come, since you're directly addressing the management issue, even if the patient is on with the Riles tube on and is on life support systems, the most important factor here to remember is that he's on all this life support because he's developed LV dysfunction because of the stent which is closed down. So all the therapies have to be directed, and we have to put our fears of UGI bleed or other bleeds aside, and we have to concentrate to get this artery open. So, you should go all out. And I personally and very strongly feel that triple therapy is the way forward. You can put these patients on injectable antithrombin inhibitor, which could be a conventional heparin or a low molecular weight heparin along with ecosprin and ticagrelor or whatever you are using, this triple therapy has to be on board. If you've had the chance of getting into the lab, I'm very fond of giving intracoronary lytics because in small doses they work very well. I am absolutely not of the opinion of putting metal into metal. I believe very strongly in doing high pressure balloon dilatations and putting intracoronary lytics and following it up with triple therapy and educating the family that, okay, I will get him back at the end of 7 days and I would like to do a check shoot to find out as to where what has gone wrong and then address it specifically. You know, Dr. Ritesh case, it was a challenging case because if you could see, it was a very tortuous vessel. It was a tortuous RCA which he had addressed, and during the primary stenting also, I feel that delivering the stent would have been a little tricky because the wire configuration during the angioplasty revealed so. So I mean, we are not sure how much COVID has contributed, and Dr. Ritesh, you didn't mention whether this patient was put on LMWH during his COVID phase of management, because
exactly.
He was put on.
Once, because it was a case of MI and primary PCI was done, so he was put on injection low molecular heparin, and there is always a financial constraint, and patient went to COVID ICU. So, but I followed her, and at least for 72 hours, heparin was given, and thereafter it was stopped. At that first admission, I wouldn't check whether what is the D-dimer level, what is the CRP level. But when she came again with the stent thrombosis, I saw the D-dimer and CRP, they were very high. Even that was after 20 days of COVID.
Kind of, It's very difficult to say whether now the D-dimer is high because of the stent thrombosis and the post fresh infarct, or because of. I feel very strongly that in a COVID state, antithrombins have got a major role to play. And you are absolutely right that because she was in a prothrombotic state, she probably ended up having a subacute stent thrombosis. So these are tricky situations, and I would rather err on the side. I have had patients post-primary, they've had stent thrombosis, and one of the patients went on IABP support. I redilated the lesion. He again he went into a state of cardiogenic shock. And I had to give full dose of lytic, because he was not in a state to be taken back into the lab, because he would have certainly with one injection of contrast or one shoot with the BP of 70, 80 on IABP, he would have certainly collapsed. So I've used full dose lytics in such patients with fairly good results. So I mean, you have to go all guns firing to salvage myocardium. Rather than worrying about bleeding, you'll still be able to manage the bleed by giving plasma therapy and blood transfusion and other things. And 9 out of 10 times, you might not need any one of them. So you must go a little aggressive in salvaging the blocked artery. And I strongly feel that adding metal to metal is not a very good choice, because in the long term, you'll have more chances of restenosis and, because of the increased metal load. So that one must avoid, if possible.
Okay. Thank you, Dr. Chadha, for this words. Dr. Varun Kumar, are you ready with the presentation?
Yes, sir. I'm
ready. Okay. We'll hear you now, please.
Okay, so just a minute. So, you have shown this, seen this, sir?
Yes, yes. You have shown this, yes.
Okay, now this is angiography of the patient. This is you can see the critical LED D1 lesion. This is Medina 1-1 lesion, the large thrombus just disturbed to the D1. And and also the D1 is quite large. This white side for go for bifurcation is stenting in this patient. And really I do in most of them this is the tap technique. So I decided to go with tap technique to the bifurcation stenting in this patient. So I wired both the arteries, LED and D1. We dilated it with 2.5 mm balloon, both the D1 and the LED. And extended the LED with 2.75 into 32 mm less. And post dilated with 3 into 9 mm balloon up to 24 ATM. So, rewire the D1 and we directed the struts across the D1 with a 2 into 10 mm balloon at 12 atm. Am I audible? Hello?
Yeah, we can hear you.
Hello? Yes. So I directed the struts across the D1 with a 2 into 10 mm balloon at 12 atm. And thereafter I tried to put a 2.5 into 16 mm stent across D1. But the stent after crossing 1 2 struts was not going further, so I pulled the stent. But while pulling, I felt resistance just near the tip of the catheter. So with some force, I tried to pull it out. And during that, the catheter got disengaged. And I thought I might have that the balloon and the stent might have dilated, so I am able to pull the stent inside the catheter. But anyway, it got inside, and when I withdrew the stent, what I saw was totally horrible. And here you can if you can make it out what actually happened, anybody can make it out what actually happened. This is the whole thing got the assembly got withdrawn from the coronaries, and I have to again engage the coronaries, and if you can make out what actually happened here. Am I audible?
Yes, you are audible. Behera, any suggestions?
Yes, sir.
Dr. Behera, any suggestions?
No, sir.
What could have?
Maybe like, yeah.
So actually what happened, now this is the scene. So this is the diagonal stent which I am trying to push across the diagonal. And you can see the one the stent struts got pulled out, and along with that it pulled the whole stent of the LED up to the and brought it up to the LMCA. So it is actually initially I thought I have dissected the after seeing the stent. I thought I have dissected the LMCA, but closely looking after the angiogram image, I realized actually the whole stent has pulled into the up to the LMCA. Now the distal stent was well opposed, but the proximal part of the stent pulled up to the LMCA. So I again rewired. It was very difficult to push the balloon across the stent struts. You can see here that there is a circle of the proximal part of the stent struts, and it was very difficult to push the balloon across the struts. Anyway, I just pushed the 3 mm balloon and dilated the whole of the segment from proximal to distal part, and thereafter I put a 3.5 into 40 mm stent which went easily across the struts of the previous stent. Hello.
Yeah, go on.
Okay. It's not running. So I stented from the proximal of the LMCA to the distal part of the as far as possible in the distal part, because the longest stent available to me was a 40 mm 3.5 mm balloon stent. So that 3.5 into 40 mm stent I across the whole of the LED. As the distal part of the stent of the first distal part of the first one well opposed with the LED head there. So there was no problem in putting the second stent. And finally, most dilated with first with the 3.5 into 9 mm balloon up to 25 atm and followed by 4 into 9 mm balloon, 8 mm balloon up to 25 atm in the LMCA. So this was the final result after putting the stent. I have to leave the diagonal as such because patient was at that time going into failure, ejection pressure was quite low, so patient was going into failure. I have to give some message to him. So I decided to abandon the process after this. I just saw that there is good chemical flow in the both diagonal and the LED. So I the lesion looking good and the segment of the stent which is pulled up into the LMCA was well opposed with the arteries after putting the stent. So this patient was subsequently shifted to ICU and was stabilized and discharged with standard medication. I plan for LCS and RCA PCI next week. But I just want to have an opinion whether do I go for the diagonal stenting in the next time or not.
Thank you, Dr. Kumar, Varun Kumar. I think the first thing probably I would do, Dr. Chadha, in this case is to image and see what has exactly happened. So the angiographic image.
I really thought first time I must have imaging tools available to us, but to our dismay that we don't have imaging modalities over here in Ranchi. So we cannot do that. So whatever we have to do with just on the angiography, we have to assess how much we have expanded the stent and
yes, Dr. Kumar, I think what the suggestion is that, before you embark on your second procedure, you need to do imaging of the LED for sure. And our friends in Abbott, I think they will be more than happy to give you a hand there. Because I think without knowing the status of your LED and the left main, you should not be proceeding with the rest of the arteries. What do you think, Dr. Chadha?
Varun, I have some comments. When I pass these comments on with the premise that we are here learning from each other. You've got a 48-year-old diabetic who came with anterior wall MI, and he developed LV dysfunction with LVF of just 30%. And I'm reasonably sure that post-COVID recovery, when he came to you, he was symptom-free. So that means we really don't know about the viability of the territory which we are assessing. So if you ask me what is my approach in a patient who's come to me post-anterior wall MI in an asymptomatic state, and he's also got lesions in the circumflex and in RPA, my first investigation of choice will be either coronary physiology. I would pick on IFR, FFR. If that is not available, I would go for a stress thallium. Because I would like to address only those segments where I know that the myocardium is viable and this patient is going to benefit. Correct? Now, we really don't know anything about this in this patient, whether the territory address was viable or not, and that is point number one. Point number two, we've got into a situation where you are trying TAP for a diagonal branch. And, I say this for the sake of learning of everyone. Force has no place in intervention, and I appreciate you. You were so honest that you admitted that I used a little bit of force to bring it out. And I I am very happy that this is going to be a lesson for you for rest of your life. You will now know that going to gym is not going to help in interventions. So I think it requires, kind of finesse, and you have to do it in a manner. So the most important factor in a tap when you're doing is opening the struts. And when you open the struts of the main branch, you don't go to 12, you go to 20 atmosphere, because you want that passage to be absolutely clear. You don't want anything to be sticking around when you're putting your stent. And the other most important factor when you're doing tap is the angle. If your angle is not 90 degrees, you have to be extremely careful. The struts are going to entangle and you're going to get into a situation. So if I'm doing LED D1 tap, I'm very, very particular. If I'm doing a circumflex or left main LED, and then I'm doing the circumflex, I'm little casual because it's a big branch. Errors are acceptable. Whereas what will happen in your stent placement when you're doing LED and D1, and that too when the angle is less than 90 degrees, you will get into a situation where you got in now. And the safest I feel for LED D1 segments are, you do a mini crush, if you're not tuned to DK crush, do a mini crush. It's a relatively simpler procedure. Finish it with the final kissing. You'll be fine. But tap with the angle less than 90 degrees and LED D1 is inviting, it requires a little bit of finesse. So that is my comment on that. And now we've ended up giving this individual multiple stents. He's a young diabetic. He's 48 years old. I have concerns about restenosis and stent failures over a period of time. So you have to be wary of this. And as Dr. Deb pointed out, you arm twist the Abbott guys who are there around you and tell them that they should get the OCT machine, or you get hold of the Boston fellows, ask them to get the IVS machine. You must image and see as to how you ended up with the first stent. And if you have the wherewithal and pushing this patient, you must get an MPI done. If not, then get a FFR done at least for the RC and circumflex, because I feel circumflex lesion is 90%, I know, but it's a terminal OM. And you do the FFR, if it is insignificant, don't add more metal to that. Absolutely don't add more metal, more restenosis. At the end of the day, we must keep in mind that it's a foreign material which we are introducing in the body, and it will certainly incite reaction, and more so in diabetics, more so in young diabetics who have a long term follow-up. So I mean, these are my thoughts on it, because post-MI situation, I'm a little sensitive about the territories, and I would like to revascularize only those territories which are viable. Then you get good long-term results. These are my comments or suggestions, and I'm open to discuss them with the platform. We have very eminent people here, and we can have a discussion on these points.
I think when at least I started my journey in intervention, there were a couple of things I was told by Dr. Sigwart. One was, don't push and don't pull. These are the two things. Things has to go like a butter. That's the way it should go. So there is nothing rocket science about the whole thing. If there is some resistance,
I didn't put that. I was just felt some resistance. By pushing it into D1, and then I thought, okay, I have to more dilate the struts.
I understand.
So I put it out. Yes. So it is not easily struts. It is not problem. Actually, at the end of the catheter, actually I got the resistance there, not in the struts, not because the struts I found resistance.
I think it's
very lucky.
I think you are being very lucky.
I have done it multiple times. I have burnt my fingers. I'm telling you honestly, I have no shame admitting that you've done it once. Maybe I would have done 3-4 times and learned my lesson. So we are here to share this only from our experience. I'm telling you honestly, I burnt my fingers by using force. So it's not, nobody is nobody is a born perfectionist. You learn basic ideas not to repeat the mistake, basic ideas to sensitize the environment, basic ideas to let others know that this is not the right way. We've had, like in the first case with Dr. Biswaranjan's case, I have lost a patient because I used force to deliver a stent, and the EBU guide dissected the left main, and I didn't pick up that dissection because I didn't check in the caudal view. I finished and the patient arrested in the ward. I've had patients where the guide has dived inside and has crushed the proximal LED stent into, the length was 20 millimeter, it became 10 millimeter. Oh, we've all gone through it. Basic idea is we'd like to share our experience so that others don't get into it. And it's, intervention is a very humbling experience. It's a very humbling experience.
Yes, sir. Beside this case, I would like to ask one question. Suppose we are doing a LED and diagonal, and all of us know that always there is single stent strategy is better than two stent strategy. Suppose there is a doubt about the side branch diameter. Suppose it's not to put a stent, but can we do? So what we do that we take a 1.5 meter of balloon, and if actually we have to see FFR whether it's significant or not. Still, if it is pinching more than 75 or 80% also, sometimes it's not FFR positive. But thing is that if you think there is a stent crossing from across the diagonal, if we are using a 1.5 meter balloon, not as a kissing balloon, just to dilate the ostium, do we need to do a kissing after that? Means if we are not using a balloon of more than 2 or 2.5 millimeter of diameter. Means, is there a chance that
I get your question. What you're saying is that if you put in a 1.5, open the strut, whether the main branch stent will get deformed or not.
Without imaging how safe it is.
I cannot answer this directly. Generally, the other thing I must tell you is, Dr. Biswaranjan, you don't achieve much by using a 1.5 opening the strut. It's neither are you ending up benefiting by opening that strut and ensuring that the diagonal continues to flow, but at the same time you will always risk the deformation of the main branch stent, so that there can be the malopposition at the opposite end of the diagonal origin. So, and in 9 out of 10 situations, you'll really get away by a professional strategy. You will get away. And I will tell you honestly, when I saw Varun's case, when he had stented the lid, the diagonal was flowing much, much better. It had a very good flow. So it was doing much better. So it is very important that there is, in fact, it's a very vast topic, assessment of a side branch is a very vast topic. And I'll tell you, there are studies where they use a term called FMM, fractional myocardial mass. The fractional myocardial mass supplied by diagonal is the least of all the branches. That is point number 1. Point number 2 is physiology is emerging as one of the major tools to, kind of win over the anatomical assessment. Whatever we see is really schemos and blocked, but physiology is the one which will guide your intervention and tell you how aggressive you need to be in this. So one must optimally utilize physiology and get guided by physiology to get good results.
And I want to add, Dr. Chadha, I think a lot of times, when you're doing physiology, you need to believe in it. That's very, very important.
Most certainly.
Once you see a physiological parameter and your anatomy, you're thinking differently, you should actually believe the physiology. A lot of times I've seen interventionalists, they do the physiology, but they go by the anatomy which they think they can see. So I think when you're doing the physiological parameters, do a good test, and I think believe in it. That's very, very important.
Absolutely, very important point.
Left main, sir, if you are doing a left main crossover from LMCA to LED, suppose you don't means that there was no complexity in the LCX. You have not done imaging, but still angiography there is no complexity to push you for a 2-stent strategy. How safe it is to have a kissing balloon, means if at all you want to for the LCX costume in long term, is there
There is absolutely no consensus on this. One school of thought says that you do a provisional, don't open the struts, and you leave it like this. There are follow-ups on FFR where they find everything is absolutely fine. The other school of thought says that there can be ingrowth of tissue, there can be platelet parts which will form over it, and eventually the circumflex will close down. But I personally very strongly feel that if you have to if you have to indulge in opening the struts and doing a kissing balloon, you must undersize the circumflex balloon. The aim is not to kind of damage and produce dissection of the circumflex. The aim is not to kind of traumatize the walls of the circumflex. Aim is just to, if it's a 2.8 circumflex, I use a 2 millimeter balloon into the strut, go high pressure and open it, because I know that I'm not going to traumatize the circumflex wall. So I mean, this is a debatable thing. The answer of this is finally is not available. So the multiple factors, the size of circumflex, the disease burden in the circumflex, the plaque morphology of the circumflex, and the dominance. If there is a dominant vessel, you are committed to do something. If there is a plaque or a cardiac, then there are no two ways about it. For a non-dominant circumflex, the aforementioned points are very important.
So we'll take the final question from Dr. Behera, and then we'll finish our session. Dr. Behera.
No, sir. With that continuation, if we only dilate the side branch and without any imaging we leave it, then we are not very sure that we may cause some dissection or not. So, and as Dr. Chadha already mentioned that we should not go only by the luminograms. So, if you have imaging facilities, you dilate and see. I think if we don't have imaging facility, it is a little risky to dilate, particularly LED diagonal. Diagonal is a smaller branch, very high chance of dissection. Little bit safer, I don't know, maybe SARS experience for LCX maybe, but definitely not for diagonal if you only dilate it in and come back.
I think, Dr. Behera, this imaging is not going to be an obligatory mechanism any further. You know, in days to come, I would say, this is going to be an absolute kind of a compulsory thing along with the angiography. And it's going to be a medical legal requirement, I am sure about it in the years to come, without imaging to do a PCI would be an incomplete job. So I think we all need to kind of get used to the imaging, because I think at the end of the day, it's like, you know, using the social media, your computers, your laptops. So imaging is just a part of life in intervention. Because if you don't do it, it's an attitude, I think, more than anything else. If you see the operators in the busy cath labs, when they're doing this imaging, it's just one step more. When you're doing a DK crush, you know, it's 8 steps, and with imaging, it's 10 steps. But you do a very, very good job, particularly when you have imaging in hand. So for diagnostic purpose, for precision stenting, which Dr. Chadha has given a lecture on, and various other parameters of interventions, imaging is becoming a must now. So I think with these comments, I would come to conclude the session. I would congratulate, and it's a privilege, Dr. Chadha, that you're with us today. And we have learned a lot from you, and I'm sure my younger colleagues have learned a lot. Yes. Dr. Ritesh Kumar, Dr. Varun Kumar, Dr. Biswaranjan, and Dr. Behera, I wish you all a very, very happy Diwali. And I'm sure that we'll be meeting up again in the non-corona era. Okay, good night.
Thank you, sir.
Thank you. Thank you, Doctor.
Thank you, one and all. A very good session. Thank you. Happy Diwali to